So they went there quite fast. So when they arrived at the scene, so they found that the patient was alert, but he was in pain and he was hypotensive. So I think in the back of the mind, there was the wrong MI. So an ECG was done at the scene, but there was no evidence of any changes of acute myocardial ischemia. So when the patient arrived in the ER, so he was
Thank you, Shah.
to the resuscitation
Chim, apa tadi?
So when we talked to the patient, so we
Sebab hujan.
that the chest pain is abruptly onset, and of course it occurs at rest because it's and he described it as a severe with a P score of 7 out of 10, and his sporadic nature, sporadic nature, and it's not radiating to anywhere. And he also confirmed that it's associated with shortness of breath. He has an episode of P score, and he was processed so you can check your different yeah. So another interesting history when we talk to the patient that the patient never provides that case. So when you go back to his past memories, he was investigated for lung lesion, remember? So he did a CT scan, CT thorax. So there is an incidental finding of aneurysmal dilatation of the descending aorta and the aortic arch measuring 4 times 3, 4.3 times 6.4 cm. But he was managed conservatively at that moment after discussion with the respective team because he was asymptomatic at home. So this really and also the finding after discussion. So he was managed conservatively. So when we examined the patient, generally his pale, his peripheries were full, and the pulse volume was poor, and capillary review time is about 2 seconds. And with the BP of 70 over 40 millimeters of mercury, so patient is in the shock, and his heart rate of 90 makes the shock reflex of less than 1. So again, complex the shock. And his heart fatigue, barely saturating under room as saturation of 94%, and his air robot. So going to the systemic examination, we checked his CDS. So there's a reason why we check everything. So the radio and radio femoral delay. So maybe you can answer now why we are checking that. And on auscultation, there's no murmur. And his gravity is not raised, no figure edema. And we are checking that because of looking for the heart function, the overloaded in heart failure. So for the radio and radio femoral, we're checking for function. And for respiratory examination, there's downward percussion over the left upper and middle lung zones. And on auscultation, there's the reduced breath sound over the left side, especially at the upper part. Abdomen was nothing. There's no muscle mass. It's soft, it's not tender, and other systems were normal. We examined the CNS, it was normal as well, and there's no features of critical ischemia as well. So, what's the differential diagnosis after we run through the history and the examination, and what investigation that you can do immediately to help you sort out your differential diagnosis? Maybe I will ask one by one because we have tons of slides. So, our provisional diagnosis that have occurred, the top of the list is aortic dissection. Given the background history, as the patient already known to have advanced stage hypertension, more receptors. So, aortic dissection leads to hypovolemic shock. So, we are looking for clinical signs of that shock. But we haven't confirmed that whether it's hypovolemic. And second in the line is acute myocardial infarction with hydrogen shock. So it's a pump problem. So we are looking at the gravity, remember, and the edema. So if patient has a pump problem, so the fluid will be dampened in other parts of the body. It's not in the intravascular, which is presented with hypovolemic as well. And subsequently, further down the list is our massive pericardial tamponade, left tension pneumothorax, and acute pericarditis of shock. There's a problem with the pipe. So the patient has a block in the pipe. So when the pump in the tank is full, but the pipe is blocked, so there will be no output. So patient will still have a hypotensive. So this is further down the list. this can go out. And further in the list, last but not least, the more common one will be septic shock. Clearly lung emphysema, but it's unlikely as well because it's sudden onset and patient is not septic, he's irritable, and he has no risk factor to be immunocompromised. He's not diabetes where I am. So septic shock is distributive shock. It's something you really attack. So when distributive shock happens, the vessels will be vasodilated, so it will be dilated. So there are more space, so your tank will be attracting more energy. So your tank becomes larger, so your volume is not enough. Okay. So the fastest thing that we can get is so you can rock a pipe. So by the time patient reaches is about 15-30 minutes after onset. So there should be some early changes if the patient has acute MI. You might not see early STI, but there will be some like tall tangent hyperactivity, but the ECG shows perfectly normal. There is no ST segment changes, sinus wiggle, there is no heart block, no capillary. So another thing that we can do is the point of care test, the blood gas. This is a quick view of how a patient status. So that first glance is not so bad. It's not acidic. The pH is normal. The bicep is also near to the normal size and 1 or 3. And the lactate is slightly elevated. So it's hypoperfusion. It's not so bad as well. And the electrolytes are okay. And more importantly, we are suspecting but the pH is normal. It's near normal for 11.9. Okay, so it's quite a reassuring. So we proceed to a bedside scan when we have got the first deadline. We are having some problem doing the scan because remember we should have some issues at the lungs. So when we try to do our echogram, looking at our heart, so we can when we do an echocardiogram, we can assess whether the heart is doing well. We can assess the rough ejection fraction, we can and if we are suspecting MI, when we do an echocardiogram, we can see some regional wall motion abnormalities. So when we try to do an echocardiogram, we cannot see the heart. We cannot see the heart properly. Okay? So when we try to look for the heart, it was actually located at quite lower down, almost at the belly, at the level of T4, where it should be visible around the left sternal edge at about to form intercostal space, but it's further down now. So we were unable to see any parietal long axis, short axis, or apical four chamber. It was all distracted. So the only thing that we can see is from is the substernal notch view. When the patient side from the side, from up down. So we are able to see the dilated aortic root, which is already already diagnosed. And there is very minimal pericardial at the effect. So that's really hard to rule out cardiac component. And we proceed further down to do a fast looking at the abdomen. So we are looking at the inferior vena cava, it was PC. So this is our pipe, this is our tank. Okay, so in our tank, it's PC, there's no fluid inside. And we also double confirm it with the collapsibility. That's so it's more than 50% collapsibility. When patient breathing, the venous return increases when breathing, so the entire IVC collapses. So means that it is underworking. And when we look at the abdominal aorta, the dilated was also normal, and we see any lab, any possible, and there's no fluid. So that is totally fine. That is part of that between this underworking. So when we do the scan of the lung, this is very interesting. So we saw a diffuse thickening visceral wall with collapsed lung picture on the left side, tilted pleural thickening, and there's a cystic mass over the left upper lobe, measuring about 6 by 9 cm, and we initially thought this was the aneurysm. Maybe it expands the left lung, but when we put a Doppler flow and the color Doppler flow, there was no flow. No color Doppler flow means there's no blood activity flowing. So this tells us that there's a huge sack of water in the left upper lobe. So at this point, we are still unable to rule out the epilepsy, but there is some mass in the lung. So we're still not sure. But I'm sorry to tell you that this is just an example. Our image that came from a patient unfortunately was lost because of storage problem with our master sound. So this is an example of image where it does look like this. That's the mass that we saw. So the next thing that we can get is a portable chest radiograph. So this is the radiograph of the patient. We do not have any baseline X-ray of the patient, just keep the CT scan, and there's no X-ray. So when we saw the X-ray, so the distinctive features that we see is the huge commonness opacity over the left upper lobe. We still don't know what it is. And the other thing is pushing away the mediastinal structure, including the subtria to the opposite side. And of course, the middle side is widened, and there is a left effusion. Okay. So this just tells us that we need to do something different, but we're still not sure. Okay. That's the mass before. And that's the deviated structure. So our immediate management was to support the area we keep the patient as a plan, as we said, quite well the over time. And we insert two large scale cannula and we subsequently balance with a lot of serotonin
Sebab kalau dia cakap tunggu keputusan lepas sebab semalam pasal dia tahu ada kajian dengan Datuk
but this is more or less the
dia ngomong lambat.
So when patients begin primary hemostatic clot in the system.
Macam malam ni kita tak ada aktiviti, kita kena tidur pukul 10. Sekurang-kurangnya contoh kalau ada berapa
and after that, we plan to do serious and send a high of course it won't come back. And we do a urgent cross-match for back cells, and also we actually notify the blood bank that we might need
to fikir
blood protocol.
Tengah fikir sekarang sebab macam ni.
So all of these need to stabilize the blood to help us diagnosis. So fortunate enough, we stabilized after the first bolus. So we managed to get
semua benda kena buat.
So this is the image that from the perspective. So as you can see, the striking feature is still the mass over the left lung. So when our radiology colleague reported that it was there, a circular aneurysm at the antinoid, and there is a discontinuity of the neurotoxicity sign at the anterior superior aspect. I think this part I will do our before, but basically it means that there is something that people when patient age, there will be toxicity at the lining of the blood vessels. So it's called neurotoxicity. So when that toxicity and we can also see increased thickness at the periaortic wall, extending back to the posterior mediastinum, and also a new large loculated hematogenous hyperdensation at the left upper. So that's so finally, we come to a diagnosis of hypovolemic shock secondary to a leaking aortic aneurysm, Stanford class C. With left lung periaortic
penting.
So this is the chronology of our patient arrived. We are trying to follow out what kind of shock he has, and we send blood and do a focus, and finally we send to the program. So the subsequent management that occurs is we refer to the CPC and also the IR teams. So because the radiology approach, the radiology that is there are uncertain source of the disease, so I asked not applicable. So urgently stomatomy and exposure was planned. However, patient and family opted for conservative management after discussion, and the patient was transferred to the pediatric hospital. So I'll pass to Dr. Ryan.
All right, thank you very much, Dr. Chim. Very good morning, professors, doctors, fellow colleagues, students, ladies and gentlemen. I'm Ryan, second year radiology trainee from Fakulti and I will be presenting the radiological findings from the CPC angiogram of thoracic abdomen. My supervisor is Dr. Ida, who unfortunately decided to today due to other commitments. Now, without further ado, I'll start. So, this is an of the thorax. With this, we can actually do the motion of the thorax that comes from the contraction of the heart. That way, there are no blurring, as you can see. On this, we just from the elevated root all the way up. Now, let me just find my pointer that we have done. So, that's good. Alright, so we do not see any motion affected. We have a clear image from the root all the way up to the elevated all the way down here and the aorta. Now, this image that you vision is actually a arterial phase study. Alright? That's why you can see that the vessels is brighter. This aortic vessels is brighter. Okay? Now, the one on this end here is the sagittal plane. The middle one here is the axial plane, and the one is another sagittal plane of a different slide. Going to the anatomy here, we can see the aortic root just going up as it goes back up first to the frontal side of the artery, subsequently the left and then the left artery. Now, on this axial image here, we can see that there is a fusiform aneurysmal dilatation just from this aneurysm all the way to the aorta, just stopping close by before it enters the left arterial artery. So not well visualized in this particular cut right here. Okay? Now, measuring from the axial plane, each diameter of this is actually about 7.5 centimeters, and the cranial caudal length is about 6.2 centimeters. You can appreciate that there is a clear, clean, smooth outline of this vessel. Okay? There's no contrast outside of this vessel to suggest any evidence of perineum. Right. Safe to say that this is a contained aneurysmal dilatation of the aorta. Now, it's also important for me to highlight that there is no evidence of aneurysmal flap, true or false, or even to say that this is a dissection. So, aside from that, we can appreciate you're not so clear the few arterial complications along this vessel wall. Now, this is very much dilated and the normal diameter for this aneurysm is 0.6 centimeters, and the arch of the aorta is also about 0.6 centimeters. So you can tell that this is almost double of its original diameter. This next slide highlights the findings of the ruptured organ treatment with COVID. Now, the initial upper half of the slide are the within 7th of February this year, and the lower half are the 31st of December of last year. So the one above is the current one, and the one below is the previous one. And this is actually a plain acquisition. Now, as you can see, through this yellow arrow indicates here, you can see a hyper-attenuated just outside surrounding the aortic artery. This is a different view of it. So, this indicates that there is some form of rupture or acute aneurysm. Now, you're wondering, why is the within the vessel not outside the heart Now, so the one
kita benda-benda
as
yang dia orang
right
dah layan,
outside here is because
dia
this
ubah,
is a much more concentrated
mungkin dia
in
nampak dia tak
a
applicable
field
dia.
which has plotted, whereby the blood within the circle here are more of
Yang
rich
sekarang
plasma and moving and stuff. So we won't see it as bright as the one
bila dia buat
outside.
lelaki,
Okay? So you can appreciate this
sekarang
is
dia
what we
dengan
call
lelaki
a
namanya
hyper-attenuating crescent
boleh
sign.
jadi
Alright?
kita bukan
Through this
cucuk balik.
plane of predictions of
Sebab
this
itu kan
study.
yang
As
saya tak
compared
di
to the
sini
previous image,
dia
do not see any of those outside of this
pasal di situ kata ada
wall here.
balik
Okay?
kau lelaki
So we do
nak mati.
see uniform
Lepas tu lelaki angkat
validation
lantai
of
balik.
this
So
image.
dia cakap apa ni rumah
Moving
nak
on.
angkat. Dia cakap
Now,
kau buat sesuatu.
this slide demonstrates
Lepas tu dia keluar
the
rumah.
more media assignment and also periodic which is another sign that would indicate a rupture of an acute aneurysm. In the plain study, and only by the yellow arrow here, you can see a hyperdense attenuating the surrounding this whole rectangular aortic arch right here, similar to the hyperattenuating that we saw earlier on in the crescent sign. Now, there are two acquisition of the image, the plane acquisition and the audio acquisition. Again, the one above is our current image and the one below is the previous image. In the arterial phase of the study, at the same time, you can see just outside the vessel here, those subtle, there is a mildly subtle hyperattenuating density just outside of this vessel here. To also confirm that there is activity, which is not appreciated in the wall has a very smooth outline right here. Whereby here is some form of break. I will show you in another slide for you to appreciate that. Even here we can see that the dense hyperdense material blood fragment is tracking down into the assignment all the way, even here as well, which is not appreciated before. Alright, this is another view in the spherical plane with two image acquisition, the plane and arterial phase. This the first two images are from the current study, and the one here is from the previous study. In the plane study, we can see again from a different view, from a different image construction, that there is a hyperdense or hyperattenuating density indicated by the yellow arrow here. Okay, in between the aortic arch, alright, and also the pulmonary artery below. In the arterial phase, again, there is a very subtle hyperattenuating density as well. In the anterior to the thoracic aorta, indicated by the orange yellow. It's very subtle. So, if we just are doing, we can see much clearer, of course. But it's not again appreciated in the previous study. Hence, confirming that there is a form of aneurysm. Now, this slide represents the arterial phase in axial view and also in sagittal view from the current and also the previous. Here, you can see from what we call existing sign. This is where you can roughly postulate the point of where you need to take. Alright? It's very subtle, it's small medium size here. And indicated by the yellow arrow, and the sagittal view as well, you can see it roughly like this, which is again not that. We can see a very nice smooth outline of the wall, where here there is a discontinuity over construction from the anterior superior aspect of the LV arch. Again, this has somewhat also caused adjusted mass effect to the left structure from a shift to the right. Now, this slide, again, the upper half of the images are actually plane acquisition in axial, coronal, and also the sagittal, whereby the one on the lower half is an arterial acquisition in the And other position in the actual test. Now, what I want to highlight here is that you can see that there is a very large loculated, what seems to be loculated, heterogeneous, hyperdense selection, occupying almost all of the left upper thorax. Okay, this forms somewhat of like a compression into the underlying structures and also the mediastinal structures as well. Now, you know, it's very heterogeneous. Why? Because all the blood production is pretty complex. And this is probably we can't tell whether it's blood or not, or how long it occurs, but it should have taken a certain amount of time for it to accumulate this much. And if there are varying ages in terms of blood products, because you see certain areas are more acidic and certain areas are more hypodense. Alright. Also, in the lower half of the image, right here, we can also see that the encapsulation factor is increased in industrial, alright, and also it is persistent as well here, increasing in the different activities. Okay? Now, this image here, I want to show that there is some more system of the blood. Right. This is the venous circulation of the image. So, as we see this hyperattenuated foci here, it appears more conspicuous and also larger as we take a delayed image. Alright. So, hence indicating that there is an activity, that there is a boost within this hyperattenuated loculated correction of the hemothorax activity. And as you can appreciate that there's also a mediastinal shift to the right. The structures are all being pushed to the right and also being pressed down here. It's more eminent here where we can see that the left lung, especially the inguinal segment and the lower lobe, is partially compressed, including all the highlight structures that go around it. Okay, so it is compressed interiorly along with the plastic surface as well. Now, again, just to highlight that there is also a right mediastinal shift. Okay. So, in summary, rupture and acute leads from a fusiform aneurysm of the arch of the aorta, as we explained earlier on, alright, with a mediastinal hematoma, and also the large loculated hemothorax with very hospitalized hematoma with an active in as shown by the pooling of the contrasted material in the as well as the space. And so these have resulted in a mediastinal shift as well as compressed left column and compressed left lung. So that's all. Thank you very much. Thank you so much for my part, I will just present about position and more of it will be management. What for 27 slides, but I will just and just to show you which part is important. Right? So everybody knows about what is journalism and what is defined as a journalism, focused journalism, more than 1.5 manager and go continue rupture progressing. Right? This is because of the war of or forest, because a lot of pathology about that. Right? A lot of probably that's also in IOTA that can cause all this. Especially in
kalau ada adik dia mesti dia orang macam dia lagi pandai dia panas.
It is important. This is the latest data in 2017. 1, 4. Alright, what's important is that it is decreasing in Europe, but it's decreasing further in Asia. Right? Because of smoking, hypertension, and that is really big at 70 for 75. And most prominent is smoking, and most prominent women. Okay, risk factors, genetic, acquired, lifestyle, and organ. This is all textbooks. All textbooks about the risk factors. For our patient is
macam nak bagi tapi tak nak bukan dia cuma nak
or smoking or after sclerosis study like that right? This is all risk factors. Our patient has hypertension. And taking the maximum diameter of 5.5, right? 5.5 naturally. Most of the curve will be just higher. Okay? Risk of rupture when it goes 5.5 and above. Right? And the other is going to be dilated 0.2 to 0.25 milliliters per year. But when it's 5.5, so the basic presentation, most of it is simple, is somatic, but patients can have a very big cancer somewhere in the back with a lot of increased dilatation and hotness of the figure. But if it's standing rupture, suddenly increase just in the back, increasing diabetic in nature, and both the diabetic quite less, and also that is right? When and rupture, patients have a bit shock, it's like inflation, rapid dropping in the box, come down to level, then have pneumonia, then have pneumothorax, outlet, he has some and there is end of the mouth, alright. This is important. This is cleaning. How to diagnose. Number one is very and the second will be I would like to define if you have a very good job alright, this is recently
beberapa hari saja
dia cakap and people who dia buat bila kita but those iotologists will like to have a very good for all the iota, including very things like we had our story from Earth. One patient has in labor
Masalahnya dia nak buat macam tu dengan orang yang ada pengalaman. Dia tak pernah buat elevator. Dia pernah buat dengan orang buat elevator. Saya balik aja dengan orang yang kelani. Sekarang ni tak tahu kini selayan jika tahu betul-betul biar dia saya baji ni yang fikir mungkin dia boleh fikir bersama kot. Dia orang mempresenter lepas bila contoh L masuk itu dia bagi STPM. Tahu tak? Dia kat belakang. Aku train lagi ni. Aku tak mana dengan jauh ni. Ya aku tak boleh lah. Aku train lagi ni. Dia macam orang macam tu dia train lah dia. Energi dia sikit. Jenis pagi je.
What is type is by location, by morphology, and by cost. By location is for the assembly, most mostly assembly at arts and also descending. Morphology, physical, secular, museum, microscopic dimension, and by cost related and closely connected. Itu macam kan?
Dia pun tak terpengaruh kan. Dia macam tak ada pendirian.
So comes then the management, right? Active management is to talk
balik awal jadi isu macam mana kita nak kawan dia orang. Dia orang dunia luar, dia orang tak ada benda fikir, dia orang tu je hidup. Kita duduk office kan, tak sabar nak balik sebab nak tutup paper, nak keluar office. Dia orang santai je balik. Kau ni hidup macam mana? Hidup tu je hidup.
I don't think pathology. I would like to tell that to the students. Usually there is a 5 things that you want or investigation.
Tak link kat sini.
One is what is pathology.
Kalau kita angkat, kalau angkat zaman macam
Where
mana?
is the pathology?
Pakai macam orang latar.
How bad is it? How bad is it? Alright, you can keep students. And before the 5 things mention by the students.
Satu kepala buat kerja, kan kerja kau tak ada pun.
Anything what you like and correlate and do that. You can see you must be one of those
Kau boleh kerja, tak ada yang kau nak keluar.
If any of us you must clean out the whole data when the correct entity. Alright? Five things in your own. Okay, that's the basic part. Okay, management is simplified open to that. What depends on students? Elective, science, surgery, program number 5, and also depends on methodology. This time, more than 6,000 when it's society, or is behaving about 5 blind research these factors, and also this one more than 5 so all this according to science and according to methodology and the technique is by where the location of the location of the methodology. IoT growth is that adaptation or transaction is the IoT growth. You can see that they can do a few things like data, surgery, or root assessment, and the assembly, and supra-priority IoT art, many art, ataupun photo and photography, and the assembly can do or by IoT group, when the repetition and group number 1 is the 5G, okay, about the repetition, and then language, alright, number 2 ialah the Austria of the okay. What we can, when we selected, then we have to do placement of the when there is placement of the path, IoT path together with all this. The other one is path spanning group. We have the path is not infected, but there is some relation supra path. Okay, let's go this right. Most of the time, use mechanical graph for the right. So this one is interpositional graph, right? At the essential graph. Not the essential graph, but it is reaching the graph, then we can do that. Heavy arc. Heavy arc placement or total arc placement. Okay, you can see the item of special arc going to be one vessel and one multiple vessels and Samat, okay, for your vessels. Or we can do this one, the larger one, frozen and the trunk to stand. Okay, first frozen and the trunk, and after that hybrid or possibly together with hybrid and conventional radiology probably you can put a stand digital to the graph. Okay, this is the main right? When we just bring out the patient's blood, cool the patient down to 16 degrees, put some medication, protect the brain, cool the patient up, cool the patient's brain, calm down the metabolic cells inside the patient's body to 16 degrees, bring the patient's blood out inside the pump. Okay? Inside the pump. And then patient is virtually dead. But you still have a virtually dead. And then you can do all this IoT work. Right? And after that, after we have done all this teaching and whatnot, we will bring back the patient's blood. So the patient, okay, goes back to the patient, and then we can start back increasing the temperature of the patient to 24, 32, and then we can start the heart again. From a big heart, bring out all the blood, and then do the surgery, bring back the blood, start the heart back. Okay? Sounds like that. Okay, one question. If so, if you make it one, where is the patient soul? Kat mana patient dirawat? Inside the pump, we have blood, everything inside the pump, blood inside the pump. Kat mana patient betul, kat mana patient betul. Right. You better think about that, right? And then you can tell me where is the patient. So, okay, all this one is in the graph. This patient probably, if you want an analysis prevention, this will be have to open up the whole descending of the data. Okay, lay out open and put it back. So this is the data. Okay, so what is schema? We have a very wonderful president over here, and I think this is one of the first pusat Kemenangan center for the country. So this is one of the best centers that not only Malaysian radiologists come to learn, but in the region as well. Okay, IVA is endovascular impact. So it covers that. Right? What is the advantage? It's minimal efficiency, no need all the jumbo in the push-up or whatnot. And rapid deployment for activity should be the first line. Should be the first line. You completed the type 3 section. For this one is huge. This one is definitely. Considering the conditions genetic authorities probably is bit difficult, especially when genetics also authorities support. So it's really go a bit relative content. So why is it favored? Especially for type B dissection. It's favored because it's structured, it's a lot of studies. There's possibilities of people. Okay, alright, and but there is some setback as well. Contohnya leaking or migration or rupture of the stem itself. I went to Thailand this early January. That is a very active angle. We try to put it active angle to that stem
Di setting semua saya akan lihat lagi segi
director, affected, they have to put it here because patient old age and whatnot, very high risk of TB. They put the TIVA, and then after a few days, the stem rupture. They put another TIVA. So this is what intervention can be done. Right? These are a few of images that you can see, and directly from the, you can categorize where is the landing zone from above down to the distal end, and you can go very down. This is what I mentioned about angulation. Right? This one area is galaxy. Okay? Right? Enough about TIVA, or this is medical and pharmacological management. We talk about this is important because it is heart rate. Okay, one of the things that I like to mention about progressive hypotension, right? In all especially energy inhibition or a dissection, there will be an increasing dissection or patients have very high blood pressure. So come down the blood pressure a bit, about permission level, probably like 65 with the urine output of 0.5, 3.1 mL per hour. That's it. Alright, and probably having well, this is 100. Just enough to put the vital organs. Alright, just the contain all the organs that. That's why I have all this anti-hypertensive. Right? What is very important is that statins stabilize the path, stabilize the pathology of the brain. Okay, this is important as well. Alright, hospital management is top protein, blood pressure control high, control rate, anemia. Okay, so we only have some to CPM and the regulation of okay, right, and then surveillance. Okay, this depends on what is type of surveillance. the time and also when to follow up. Okay, like generative in that science, you will annually, but generative in this science, you will every 6 months. You want to generative like catch. When is the optimal time to do such intervention? This is ataupun dibahas. Alright, and also all this including where is the site of the aneurysm, you must be scan or input, it can do right. So these complications, most of it is all this hypovolemic shock, as the patient presented, but patient can have a lot of things as well. Cardiac pneumonia, aortic circulation, coronary artery involvement because it might have infarction, stroke, when there's a lot of debris going up to the brain, spinal cord ischemia, block arteries, all this are presented to you by Prof. Chim, and this is what we need to see during presentation. Okay, right. Why is this crucial? Because in 1 to 2% per hour after dissection, then after dissection in the first 20 hours, it's actually 1 to 2 second life. Alright, in terms of totality, even though come to hospital, the 2 to 30% without any emergency impact, patient can die. So 20% emergency misdefined also. Alright, all those without intervention is gravely injury. So we have to number one diagnose quickly and also do some intervention as soon as possible. Unfortunately, the patient has lost family members, several years old, very bad in complexities. The family member that wants to benefit, then that's right? Okay, I think it's important. CPA is school now. Alright, that pressure, little block, swimming time, distance, and centers, especially in this area. Thank you so much. Okay, thank you, Mr. John. To make things short, see what is the most common presentation I can tell you. Patient working various complaints and symptoms, and one of the signs is their BP low. People get jumpy, people get worried. So hopefully, my short session will highlight to you what we do in BP and how we approach such cases. So hypotension, what is shock? Okay, by definition, the organ will not receive enough blood supply from the heart, because of a pump problem, tank problem, or pipe problem, and to make the ECG mark. That is what is shock. So as my colleague said, we talk about 4 kinds of shock: there's hypovolemic, obstructive, cardiogenic, and also distributive. So when we see patient majority presented with hypotension, tachycardia, together with bradycardia, with trauma, with sepsis. So we has come up with a way how to sort this kind of patient into what is the most appropriate investigation and management. Okay, one of the things that you heard today is focus. POCUS. So it's basically a point of care ultrasound that we use in the emergency department to detect all this kind of presentation. And one of the protocol is rapid ultrasound in hypotension. What does it do? It looks at the 3 things that my colleague talked to you about. When the patient is hypotensive, could it be? The question is, could it be? Is it a pump problem? Is it a tank problem? Or is it the pipe problem? Does the pump able to work efficiently to pump the blood into the circulation? Does the tank have enough volume to sustain the circulation? And does anywhere in the circulatory there broken or not? Okay. So when you go to farm landmark manufacturing, you're looking at the conductivity of the heart, not so much muscle as the cardiologist to measure it yet. Just want to see is the heart muscle contracted very good, suboptimal, or there is any regional wall motion abnormality. We also want to look at is the diameter between the right ventricle versus the left ventricle is abnormal. Then we also want to look at that. I think most of you know about fast focus sonography trauma. So there is some part of the method that is incorporated, looking at the IBC, okay, looking at the connectivity index. Okay, we also looking if there is blood and if the patient is hypotensive, the abdomen is clear, could blood somewhere else. For example, in the thorax, so we do the lung ultrasound to look for any sign of VI or diffusion. And finally, we look at the part. The main part is the abdomen. We want to look at the aorta. If there is leaking there, or if there is aneurysm there, okay. And we also want to look into the system. In the case of TB, that can be exposed to TB, we want to look whether the problem is with the flow of the blood. Okay, so these are the features that when you do the RAF protocol, looking heart, lung, and abdomen, vessels, we want to distinguish which of these is most likely happening to the patient in front of you who is having hypotension, maybe tachycardia, or predicament. Okay, some example. This is not the image from the patient, but just want to share with you. Okay, as you can see, this is the flat view, the parasitial long axis view of the heart. The arrow is showing where the root is slightly bigger than normal. Normal is 11.5. This is the parasitial view as what looking at the heart and the from your parasitial norm. You can see here there is a big adaptation of the aortic arch. Okay, and this is what Azlan was mentioned here when we did the corridor flow, corridor view on the patient. If there is a flow of blood into the effect, you will see blue on the sun. Okay, where is an example of aortic. Okay, here is a common view you will see in the when you get looking at the heart, looking for pericardial effusion. Usually there is some fluids in the pericardial sac, but when it's too big, it becomes suppressed so that it prevents the heart from resisting flexing optimal, and hence the period will be compromised. Okay, so back to our case. We will not see that we had a history of genetic some aortic problem before from the previous step. That kind of direct us to what we should do to confirm the diagnosis. Okay, but as you can see, the literature protocol shows tell you to look for something when you do the focus, but in our cases, the patient abdomen scan was negative. There was some positive finding when we scan the heart. There is some positive finding when we scan the heart, but nothing is textbook. Okay, so that raises a question: focus on ultrasound is not something that you need as a second option, because what focus does is very rapid, real time. I think most of the sectors in Malaysia have ultrasound department, so it's very available. For us, if let's say that we don't have the machines and the certificate, we have to rely on our technical. That will take some time and that will further develop the safety of the patient. Okay, so that's all from me. Put a bit of time, 5 minutes extra. First of all, please a round of applause to all the speakers. For the excellent presentation and sharing. I think it's a very comprehensive presentation where we covered from the department of fresh presentation and differentiated shock, how we approach it, how the dilemma brought us to bring the regulatory input, and where the regulators come in with their expertise and share their insight on the importance of the investigated CCA. And then we refer to the regulatory surgeon because what we find the cost, then we get to the input of the surgeon, whether or not to open up the patient. And we wrap up with the importance of focus by Sharifuddin on how in the unprecedented state of the patient, we don't know what is actually the cause of the heart failure or the cause of the low BP in a very confusing situation. There are some tools in the ECG, some tools in the neurology, and of course tools in the management that can help us as doctors in the future, in the management of the patient. So, as a take-home message, I want maybe because of time, we have time for Q&A, I think, because I know some of you have classes. But the take-home message that is important for us, all of us to learn from this case, number one, the importance of multidisciplinary approach in any case that we manage. This is where the ED, the surgeon, the neurology, the physicians come in. There's one more thing involved that I caught the physician as well, because she was managing the case 2 months earlier. So inputs from all angles are needed in order to get the best from this patient. Secondly, the approach for uninitiated cases, something that you learn, sometimes in textbooks, you learn specific cases, but you have to have high index of suspicion when it comes to patients who present with, malnutrition syndrome or unexplained symptoms. And the take-home message for erectile dissection or erectile syndrome is always any unexplained neurological symptoms is the section under government. But that's a mantra. However, in this case, if you apply that question, it doesn't have any neurological symptoms that can narrow us in terms of suspecting that section as the diagnosis. So, first of all, finally, I thank you all of you for your attention. And again, we hope to see you in the next CPC. And another round of applause to our presenters for their excellent contributions. If you have time, you can come forward and ask questions, or maybe any burning question or ask for the